one thing, and I want you to understand that that's what I've committed to do, and I hope that some of you will join me. Thank you very much.
Okay, good afternoon. Boy, what an exciting day this has been. Congratulations, Hattie and Right Care, for all you've done. It's been an amazing journey. I'm excited because we're going to debut a video here today that No More Broken Hearts did with the California Chronic Care Coalition, and I'll be showing in just a second. But I just wanted to, I have like 4 minutes, so I'm gonna go as quickly as I can. This is some of the programs and projects that the California Chronic Care Coalition is working on, but I want you to look at the top line. In a Heartbeat, Carrie's Touch, No More Broken Hearts, My Patient Rights, SHAPE, and the Chronic Care Policy Alliance. So we are working right now with, and in collaboration with HealthNet, In a Heartbeat, Carrie's Touch, and HealthNet and the Chronic Care Coalition to go into the African American community and try to replicate what we started in San Diego, in Southeast San Diego. I sat down recently with one of our African American ministers to kind of go over. I know you have heard the news. It's hard not to hear the news, is what's been going on in Sacramento over the last couple of weeks when Stephon Clark was shot and killed. It has created havoc in our city and havoc within the Black community. We have been working within the Black community, and thank you for bringing that up, because there is no excuse for anybody to have such a disparity that they have to worry about not only what's happening in their community, but having a heart attack or a stroke. When it's preventable. So we have, we've put together a project. One of the things you see here that's part of the project, and I don't know, maybe it goes there. This is our digital pill bottle. We also have the coronary artery calcification bus. We have a bus that's fitted with a CT scan. It can also do the lungs. It can also have a lot of the other screenings to go into these diverse communities and really start working with people so we can diagnose them and get the help that they need. The other thing that we've been doing, and talk about patient engagement, because everything that our group does has to do with patient engagement, whether it's engaging lawmakers, whether it's engaging physicians or stakeholders or opinion leaders or the media. Everything that our group does has some kind of engagement piece to it. This last year, one thing I didn't know in my lifetime, that I would end up becoming an executive producer of videos. But thanks to our friend Victoria, she introduced me to Cutting Edge Productions and Chuck Dorshik, and we have been attached at the hip since we met. And we've been going all over the state doing videos, and they've gained such notoriety. These are some of the people we did. Alan Fremont on innovation, and his is awesome, and I'll be happy to show it to you later. And then some of our women telling their stories. There's nothing better than going into somebody's home to get their story. It's real. There's no spin to it. The media can't change it. It's a real way to capture the information. So I want to take you over now to our video. Here's the debut.
Coronary heart disease kills more people each year in the U.S. than cancer, accidents, and HIV/AIDS combined. There's a simple, quick, and non-invasive test that could save more than 960,000 lives and $350 billion annually. But most insurance companies refuse to cover it.
Coronary artery calcium scan is a CT scan of the chest that can detect calcification or calcium buildup in the coronary arteries.
More than 60% of men and nearly half of all women didn't have any symptoms before suffering a heart attack. Marcus Nahara says if he hadn't taken the test, he would never have known he's at risk.
My heart is not that healthy for someone who is 44 years old. And to be honest with you, the part for me that was the most resounding was, I know I'm not the only one, but at least I know, and I can do something about it.
Marcus' score was 139. He talked with his doctor about next steps.
Immediately, I've dropped red meat and whiskey from my diet. I don't miss it at all. I'm onto a lot of fish. I'm doing a green smoothie every morning.
Sandy Steck just wanted some peace of mind.
I didn't know the scan existed. I didn't know you could actually test for heart disease. And it's something I read about all the time. It's something I've heard of, but it's never something I knew I could just walk in and do a quick scan and find out the results.
Because her scan wasn't covered, Sandy says her doctor didn't even tell her it was an option. She found out about the scan from a friend. Until this exam becomes as common as a colonoscopy or mammogram and covered by all insurance companies, people are at risk and doctors will remain hamstrung.
It's so frustrating to learn that somebody had a heart attack, maybe had a heart attack and died, and it could have been prevented if only they had known that they were at increased risk, that they had atherosclerosis in them that could have been detected, could have been treated had they known.
So we're putting more heart and soul into the work that we're doing. We're stepping things up. We're going to get the action mounted. We've put together a cardiology public policy team. We're working on legislation for next year, and we're going to get all our ducks in a row before we go in there. On that team, we're so thrilled to have Dr. Balmer, Dr. Nagavi, Dr. Marin, Dr. Budoff, and Dr. Sky. And if I've missed anybody, let me know. I'm sorry. And then No More Broken Hearts and the Chronic Care Coalition and the California Health Collaborative and all of us that are working so hard to get the coverage that we need, because nobody should die of something that's preventable, ever. So we're bumping it up. So thank you so much.
Hey, Liz. Hey, Liz. Oh. I just want to add one thing. Marcus there had been managing his diabetes and his high blood pressure for over 10 years. He had a huge family history and never knew anything about getting his heart checked out. So, and you can see now that he know what his score was, he's doing everything he can to make sure that he doesn't end up with a heart attack.
Thank you, Liz, and all of you. That's absolutely terrific. So what I'm going to try to do in about the next 4 to 5 minutes or so is talk about what we've been learning around patient engagement, working with two of large accountable care organizations around the country, Advocate in Chicago and Healthcare Partners, DaVita Healthcare Partners in Los Angeles, now bought out. They're now Optum Healthcare Partners. So for the past 2 to 3 years, Hector Rodriguez and I and our team at Berkeley, Susan Ivey and others, have had a grant from the Patient-Centered Outcomes Research Institute, one of only probably 2 or 3 in this area, to look at patient engagement issues and what's really going to be needed to do some of the things we've talked about today. So if we could call that up, the slides, and we'll get started. Slides. Yeah, Megan, the slides. I can talk it through, but it's not quite as exciting.
The last one of the day.
Oh, okay, she'll get them up. Well, one of the things I want to say, this is our 10th birthday, right, of the Right Care Initiative. It is also the 75th anniversary of our School of Public Health at Berkeley, at UC Berkeley. And we're going to celebrate it on April 21st. Some of you hopefully will be there. Some of you, of course, are alums. And for the first time in the school's history, it will bring our core teaching faculty together. We've been spread out over the Berkeley campus, but we're going to be in a brand new building If you know the area, it's on the corner of Shattuck and Hearst. It's that big building going up. We will share it with our Department of Psychology and our Department of Education, which we think will build some further bridges with those units on campus as well. And it's an opportunity here now to name the school, okay? It goes for $50 million, okay? So I think, you know, the Penso School of Public Health at UC Berkeley, that works, you know. Just looking around the room, the James Duddle School of Public Health at Berkeley, you know, that would be good, you know. I could go on and on, but if that's a little bit of a reach for some of you, or maybe you have friends, for $30 million, just $30 million, you get your name on the building, okay? Etched, you know, if you like block letters, that's up to you. Like script, you know, $30 million. But seriously, those are going to be opportunities. We'll see if they get realized. So I'm just going to keep talking. You know, you're just going to have to visualize this. I checked when I came in, but I guess it didn't come off. So basically, what we did is, as I said, we're looking at these two ACOs, and we're basically cardiovascular patients with cardiovascular disease and diabetes, a couple thousand of them. And we had 8 primary care practices in both of these ACOs, and we gave them a baseline instrument after scanning the literature and doing some preliminary studies of about 39 or so activities they could be doing to engage patients. And these are like motivational interviewing, shared decision-making, shared goals, et cetera, et cetera. And so we got a baseline, and we divided them then into the top quartile and the bottom quartile. And we sampled 4 practices from each of those because we wanted to spread out the variance. And then what we did is we collected data on patients, clinical data, and patient data, and we looked at 3 patient-reported outcomes, in addition to the LDLs, blood sugar levels, and so on. So we looked at the physical functioning. These are the promised patient-reported outcomes measurement set that's available. We looked at social functioning. We also looked at emotional functioning as well, depression and anxiety. And we looked at this at 2 points in time to look at it over time. It was not a structured intervention. These were 2 ACOs that kind of were naturally trying to engage their patients more, and we wanted to see if through this process they were succeeding in doing this, and then was it really related to patient-reported outcomes as well. But we did manage to feed back the results from the first year to see whether or not they would act upon it to make some changes perhaps in terms of the second year of measurement. And what we found, sort of cutting to the quick, was first of all, no surprise because it's also been documented in the literature before we did this particular study, although in a different way. Okay, great, thanks a lot for bringing that up. I've talked through most of this, I've talked through that. You know, that, by the way, is something to realize. That's overall $2 trillion. Okay, this is really going, there's the measures we have. And all of these have been validated, high reliability. So we're looking at patient-reported outcomes. Those are the questions, right? I've taken us through this. I should say a little bit, in addition to these instruments, we measured systematically what these primary care practices were doing in terms of how well they related to each other, a concept called relational coordination, shared goals, shared information, mutual trust, accurate, timely communication, problem-solving communication. They each evaluated each other, the primary care physician, the nurse, the medical assistant, the diabetic nurse educator, the social worker if they had one, the receptionist, etc. We measured teamwork facilitation. You heard some of this today was measured. We measured how responsive they were to patients, patient responsiveness, which is an adaptation of the Baldrige Award, and a number of other measures. So that's the 700 you see there. We did 2 years of on-site interviews where we would go out and interview these people as well, and then the random sample of patients for which we had an over 50% response rate to that. So here's what we found. More engaged patients had better patient-reported outcomes of care across the board. And that just simply validates what is existing in the literature, as you might imagine. The question is, how do you get more engaged patients? What can primary care practices do? As you can see here, we did find, in fact, the issue about depression that came up earlier today. Treat the depression first before you can get them then motivated to do some of the other things that need to be done. We found that those patients with one or more mental health comorbid conditions, in addition to their diabetes or cardiovascular disease, but who were highly engaged, were 4 times more likely to score very high on the social functioning scale. It was also true for physical and the emotional, but it wasn't statistically significant, but it certainly was for their social functioning. Practices that did more to engage patients had better coordinated care among team members and more responsive to patients, but such practices did not have patients with better patient-reported outcomes, nor, by the way, did they have patients that were more engaged. So what's going on? This is the advantage of mixed methods studies, where to get behind the regression coefficients in the quantitative data, you go into the field, talk to people, get close to the problem, see whether or not some of the self-report and secondary data is actually being implemented in practice. And when we did that, this is what we found out. There was limited understanding on the part of these practices, really, of what some of these behaviors involve. And to give you an idea of some fairly typical quotes or experiences around motivational interviewing, more than one, but the one I remembered in an interview I had said, oh yeah, we are taught in medical school how to communicate with patients. You know, we have a module on that. That was their idea of motivational interviewing, and as you know, that's not what it is. There's actually training in this, et cetera, et cetera. An idea of shared decision making is, oh yeah, when the patient leaves the office, they have pamphlets they can pick up, and they can read them, and then we encourage them, those can be decision aids as a part of overall shared decision making, but it's much more than that. We also came across a very interesting tension, something for us to think about, where we noticed in these 2 ACOs there was a lot of time and effort being devoted to hitting clinical targets. Some of the targets we talked about today, in which we were told by the people we were interviewing, it created a tension in them in terms of limited time to spend with patients, engaging them around other kinds of issues. And again, this was a function of some of them weren't learning to delegate, to make use of the team, to have a pharmacist on the care team that can take care of some of this, so you can, do some of these other things. So this was a dynamic as well. So it's really in the execution and the implementation that a lot of attention needs to be given. If you're interested in an article in JGIM a few months ago, and then also Margie Knox in terms of some of the engagement strategies in the community that these practices were engaged in. Funded by our funders here, mainly P. Corey, but also the Betty and Gordon Moore Foundation, ARC, and again, Blue Shield of California that gave us the gift earlier today. So that's where we are at. We're going to try to continue some of this work as well. Thank you very much. So now, and I could have done that without the slides, I just needed 2 or 3 more to go, but no, thank you. So let's get the last panel up here quickly. We've got...
So can I just say one thing as people are moving?
LaVonna.
April is Minority Health Month, on April the 27th, we're having an event at USC that talks about the partnership in terms of health equity between government, research, and practice, and you're all invited. If you want more information, please see me.
Very good. Thank you. So as our final panel comes up, I'm going to say who we have here, and then maybe we can just speak from our seats in terms of saving some time. We've got the microphones there. So we have Carol Zaher is here, and Carol is the medical director at HealthNet, a cardiologist. She's going to be with us. Dr. Jeff Mason, he's now retired, but was the medical director at United Health Plan of California. Dr. Joseph Skye, who's Chief of Cardiology, Medical Director, Heart Lung Vascular Center at the Travis Air Force Base. Marcus Thygesen, Dr. Thygesen's retired CMO, Blue Shield of California, and doing some work with us at Choir. Marilyn Stebbins is USC School of Pharmacy, and she's Innovations Director at UCSF. And then Dr. Matthew Wanacott, who's retired from the Airforce, but he's Medical Director now at Barton Health Community Clinics. He's also co-chair of the Capital Region University of Best Practices. And what we've asked them to do is to share with us just 3 minutes each, because we have 6 of them and probably about 18 minutes here, share with us the one thing they would do to get to zero, given what we've heard today and their experience. So we're going to start with Carol and just kind of work across. So Carol?
Hi, thank you very much. Hattie originally asked to give our insights in 8 words or less, which was a little bit of a challenge, but what I came up with was it takes a village, which was mentioned earlier today, but make it simple. Now, I know that sounds contradictory because medicine, patients, our healthcare systems, our coverage, et cetera, are very complex, and we're all complex thinkers. We enjoy that part. But I think I'm a simple person when it comes to solutions. And what I mean by that is that I like to simplify things. I have a rule of 3s often that I try to work with just 3, maybe 5 if I really want to expand it, to make changes in small amounts and then progress from there. So that's a very simplistic overview. I will say that Hattie also knows that I have a penchant for artificial intelligence, which was just mentioned briefly in some of the programs today, and I loved Dr. Baumer's Circle of Zero with all those complex entities that would be entailed in artificial intelligence. So what I'd like to say, though, is I think that artificial intelligence is coming to a theater near you. It's not for prime time yet, but I think we will get there. And I think that as complex as AI could be to make and to do all the data entry and create the data systems and gather all the knowledge and the integration of IT that's needed, it will simplify what we as practitioners do and with our patients. Because whatever we try to do, I think we should think of our plans with all these great programs we heard today, very innovative, interesting, and impressive, that what it comes down to is that provider-patient interaction. If the provider doesn't do or help the patient do what the patient needs to do, and the patient doesn't do what they need to do, as complex as we may think, it's not going to help. So I think with every plan that we try to take away from a meeting like this is to think complexly, but make our solutions as simple for the end users as possible so they'll be translated into action. So that's my 3 minutes.
Great, thanks, Carol. Well done. Good example for the others. We'll move on then to Jeff.
I want to thank all of you for being here and sticking it out till the end. Actually, this has been a wonderful presentation, and Hattie is to be commended, as everybody said already. What I want to say is very simple, but I think it's meaningful. And it touches on the role of accountability, which has been mentioned several times already today. In public safety, I think there's a rule that says if you see something, say something, or something along those lines. In healthcare, I think it plays out to the extent that if you see something, you need to do something. You can't ignore it. And I particularly want to stress the role of specialty care in the fact that specialty physicians especially tend to be very focused on what they believe to be the problem is that the patient came when it's in their specialty, but they have a general blind spot about things that they perceive as being outside of their specialty. And Jim Duddle and Kaiser have modeled an accountability role which basically says that everybody in the organization is responsible for these basic health issues like risk factor reductions, blood pressure, lipids, diabetic control, and some of the behavioral things like addiction. and risky behavior and things like that. I think if everybody felt that it was their role in the organization to be aware of and to respond to patients who have these issues, I think it would go a long ways towards us making more progress than we're making right now. Thanks.
Thank you, Jeff. Yes, yeah. Yeah. Joe.
Last time I gave a talk, Warren Barnes actually said to me that you've been very lucky that you've gotten to do a lot of interesting things, and I had to think about that for a while, and I think one of the most interesting things I've done in the Air Force was take care of fighter pilots, both men and women, and what I learned from them is that when you have highly motivated patients that develop hypertension or metabolic syndrome or prediabetes or develop a waist measurement that doesn't pass fitness standards, that they are highly motivated. And it's amazing what doctors and patients can do together when you have this motivation. And now that I no longer get to do that, the challenge I've had as a general clinical cardiologist is how to motivate the average person to be invested in their health care. And going back, though, to my experience with aviators and other high-risk occupations, we found collectively for the Air Force that when we used all of the things that Dr. Baumer so eloquently laid out with much of the inner heart equation, that if we could motivate someone to maintain a waist, if we could look at their lipids, including sometimes advanced lipids, if we could monitor all of the right parameters and give patients good information, that compared to an age-matched population with a major adverse cardiac event risk of maybe 0.5 to 0.7% per year, we achieved for our population about 0.15%, probably less. And that taught me that this is possible to modify these risks if you can get the patients invested. The last few years have been a challenge in motivating patients, and my favorite example of this is now identifying what someone's goals are and then waiting them out to make sure that they've listed them all out, and then asking them what they're willing to do. What do you want to do to achieve those goals? And I'm very comfortable with very long periods of silence. I have not told someone they need to lose weight in probably a couple of years. I get them to say it if that's what they want to do, if they're trying to achieve something. Same with all of the other behaviors. If somebody wants to quit smoking, they're going to say it. I'm going to wait them out, and if they don't, then I work with them where they are and what their motivations are. And so, as has been so eloquently presented by many other speakers, I think patient engagement and us giving them accurate data that they can understand and use to motivate themselves with is the secret to getting to zero.
Great. Thank you. So, Marcus?
Yeah, I'll piggyback on that. I am struck by the story at Health Partners about sort of the series of care model innovations that they've gone through over the last couple decades to get to D5 levels that are in the 50% and better range for the whole state of Minnesota. And just to give you some context, 15 years ago, the comprehensive D5 measure for diabetics at Health Partners was about 4%. So they've increased their ability to deliver optimal diabetes care by about 1,000%. But they've done that in a series of care process changes over time, and they've been very goal-seeking, and I think we've heard other presenters today talk about that. And so I think that model of progressive structural care model innovation is what is going to be required to get us to zero. But I also think that where we've kind of fallen short and we need to make a lot more progress is in this patient-person engagement area in terms of figuring out ways to continue to innovate with respect to the care model to enable people to make the changes in their lives that they need to make to eliminate avoidable risk for cardiovascular disease. And my guess is that those future care models will look very different from certainly the traditional care model. I'll just close by saying that one of my big concerns in California is how do we address the still large proportion of our fellow citizens who receive their